I have no conflicts of interest in relation to this particular presentation. So this is a little bit the layout of the presentation per se. First, I will talk about fevers, the definition of fever, and some general concepts, hopefully some helpful concepts you can go back to your patients and the parents of your patients. And then we will get into the gist of the talk itself. I will be talking about fevers in the neonatal populations a little bit, also in the young infant, those folks who are less than 3 months of age. And then from there we will move on to talking about fevers in the older infants and children. And then moving on to the pediatric patient who has recurrent infections, recurrent fevers. So this is one of the recurrent themes that I get into my pediatric outpatient ID practice. So hopefully I can share some thoughts with you in regards to those folks who come to see me with recurrent infections, recurrent fever in my practice. And then finally, I will talk a little bit about recurrent fever syndromes, not particularly an infectious diseases problem per se, but this is how these things start off with us. So let's start by a few slides with definitions. Fever, as you know, is a prominent but non-specific symptom of many different disease processes. I like to think about it as an intersection of many pathological or pathophysiological processes. It's clearly non-specific. Its presence tells you something is wrong, but it's up to you, to the family and to the patients when appropriate, to try to unravel, the secrets, the underlying process behind that. It's an abnormal elevation in the body course temperature, and this is something to keep in mind. What elevated is elevated, and we'll get to this in the next slide, hopefully. We still don't know if fever is harmful or not. Is it harmful? Is it beneficial? We have some animal studies now, sort of from many years ago, actually. Other than the obvious, causing discomfort, causing problems with dehydration, just because of the increase in the body metabolic rates and, the cardiovascular and respiratory demands. We know, at least from animal studies, that high-grade fevers can cause some problems with your immunity, your immune responses to microbes. It can decrease phagocytosis, and those elements and those white cell responses against pathogen might also be dampened, again at high fevers, probably 39 degrees, 40 degrees and higher. In moderate grade elevations, 38 or 39 degrees, we think that it can actually enhance part of our immunological responses. And one way we think that happens is that at these moderate elevations of temperature, we think there might be some inhibition or decrease of bacterial growth and viral replication. So what is fever? We can get fevers through many different orifices of the body, many different ways. Rectal is one, axillary is another one, orally, and more recently, we obtain fevers through the temporal artery. So traditionally, and in neonates in particular, the best way to obtain temperature is through the rectal vault, rectally. And it's just because most of the studies that try to associate the incidence of significant or invasive bacterial infections and the amount of the fever or the height of the fever, or in a febrile child, has used the rectal thermometry as their gold standard. It does remain the gold standard, specifically in neonates and the young infant and children. So this is important to note. So 38, 100.4, 38 degrees Celsius and 100.4 degrees Fahrenheit is generally regarded as fever rectally in this patient population. Now, in older children, try to get a rectal temperature on a 6-year-old. So in older children and in adults, oral temperatures suffice. And the fevers in this particular perspective is defined at anything more than 37.8. So clearly, a 38 is fevers. Now, we should always try to remember that, the rectal temperature is probably the best manifestation of the core body temperature. TA comes close. The studies are a little bit sort of in disagreement if this is correct or not. But you might want to think about TA, specifically in TAs with good brands, as mirroring rectal temperature to some degree of accuracy. Other temperature, like axillary and orally, probably there might be a difference of 0.5 to 1 degrees Celsius in this particular population compared to the rectal temperature. So important to note. And again, when I see patients with fevers, I tell them about some general concepts, some general thoughts that fever is probably a manifestation of a disease phenotype rather than a disease itself. It's not an illness itself. And then the therapy, hence, for fever is not mandatory. Again, replacement of fluid, rest, just to counter those increased metabolic demands are certainly suggested. But, treating it or not is like a matter of comfort. It's just a matter of let's have this child who's febrile and sick at times just be a little bit more comfortable. Whether it works and shortens the disease processes or the duration of an infection, that is certainly not the case. We should continue to reassure our patients, our families, that fevers do not cause end organ damage. They don't fry your brain. They're not going to cause you to lose faculties or abilities or proceed into damaging some organs as we move along. Even in febrile seizures, in the olden days, everybody who shows up with febrile seizures gets an LP, and we are just all over him or her trying to just control the fever to the best of our ability. Now we know that an LP is not necessary for febrile seizures, and the role of fever control in febrile seizures, even in febrile seizures, is very debatable, controversial still. Please remember, if you do decide, or when you do decide to use antiparesis, just make sure to dose by weight. That's very important, and to avoid toxicities. A lot of the over-the-counter products, formulations, do contain some Tylenol or other antipyretics in them as well. So it's very important, crucial actually, to just make sure that when we suggest using acetaminophen, just to make sure there are no other acetaminophen-containing products that are used concomitantly. So important to tell the families about this particular thing. We've seen hepatitis, transaminitis, and significant liver toxicity in a few cases where concomitant use has been documented. And one thing which is a pet peeve of mine, let those kids rest. They're very tired. They're febrile, probably sleepy, trying to just convalesce or recover from their infection. So it's certainly not mandated or necessary to wake them up from sleep to just give them that dose of acetaminophen. So sprinkled into the actual talk, I've actually pulled in a few cases in there. I think there were 2 or 3 cases, and depending on time, we will see if we can go into all of them. These slides will be available to you, by the way, so you can actually review them at your leisure. But let's go through case number 1, and that will be used as a springboard to try to start talking about fevers in the neonate and the young child. So let's review this together for a moment. So this is case number 1. And all these are not made-up cases, by the way, so these are cases that I have seen myself or heard about from colleagues. So 20 days old, so a brand new baby who was seen in the emergency room for rectal temperature documented at home to 101.1. So a true fever and some increased fussiness. He was still nursing vigorously, and no other symptoms were present. Few details for you guys to know about. This baby was delivered by C-section. I think it was failure to progress, but no other infectious processes perinatally or during or after delivery. His mom was documented GBS negative, group B strep negative, and there had been no sick contacts at home. That child was an only child, and there were no maternal or paternal history of genital or oral herpes simplex virus. So in the emergency room, his physical exam was totally normal. He had lower grade fever, but still, febrile, and this measurement was done rectally, 100.6. His heart rate was 140, breathing fine, and he was not hypoxemic. So no rashes were documented. The baby was arousing appropriately. He was crying, when touched, and when an IV was inserted. He certainly was, fussy and crying, but he was easily consolable. Now, let's go to his labs. Most of you will know in this age group it's a fever, so we do the full septic workup. So let's go over these labs a little bit and see what we can, things we can sort of highlight. A CBC showed no significant abnormalities, perhaps a white cell count a little bit on the high side, and some lymphocytic predominance, 59 lymphocytes and 13 monocytes. Chem7 would include electrolytes and BUN and creatinine. Those were normal. Bilirubin, probably normal for age, 0.7 over 0.1. But as you can see, there is some degree of transaminitis there that you can see. ALT, more liver specific, 165. Our normal is probably up to 40, perhaps 50. AST is 204. So some increased transaminitis that were documented. His UA was normal. We did get a catheterized specimen in there. Blood, urine, and CSF cultures were pending at the time. But as you can see, the CSF formula was a bit abnormal. A normal glucose, normal protein for age, an RBC count that is a total 0, but some white cell count there, 86, and most of them were lymphocytes. So 69% lymphocytes and 28 macrophages, just a few sprinkled segs in there. Now is the question, what is the most appropriate next step? And I have here 4 different clinical scenarios. Let's go over those very quickly. So A, send home with careful observation and instruct the family just to come back if the fever is rectally more than 102. B, admit to the hospital, but not before giving ampicillin and gentamicin on an urgent basis, and follow up these cultures closely. C, ceftriaxone, CT-axis ceftriaxone monotherapy should be sufficient in this age group for neonatal pathogens, and make sure to use meningitic doses. We've documented CSF pleocytosis, so 100 per kilo would be the dose to use. And then D, use a cyclovir, a gentamicin, and ampicillin. ACV is a cyclovir, and that would be the optimal coverage for this particular neonate. So before we try to answer this question, let's talk about fevers in the neonates. So neonatal fever, fevers in young infants, those who are less than 3 months of age. So in this age group, we have to be very, very careful. Their immune system is very incompetent. There's no learned immunity. There's no adaptive immunity. And all their immunity is basically just the innate one, a very crude way to fight viruses and bacteria. So one, they do not have the sufficient immunological profile to fight off infection, ward off infection. And 2, and perhaps because of that, their symptom, even in serious infections, may be very minimal, just perhaps a fever. So the incidence of serious bacterial infections is higher in these infants and neonates. It's probably the highest compared to any other time in childhood and perhaps in adulthood as well. So this is a high-risk age group with tools that are much less than optimal. So this is a study from Texas Children's Hospital, I believe, and this was done a few years back. Cavanis et al. Tried to look into all hospitalized kids, neonates in this particular study, just any kid who is less than 24 or 28 rather days of life, any patient admitted to the hospital, with or without fever, or even with low temperature, and trying to figure out what is the incidence. This study was particularly geared towards herpes simplex virus, but we can glean a lot of other information from it per se. So moving on to the table in that study that I find most informative. So if I can direct your attention to the very first line right here. So in all neonates, and they had 5,000-6,000 neonates admitted to the hospital. I think it was during a year or two. And they found in all this group an incidence of a viral infection of around 8.5 or 8.6 if you want to include HSV also in there. And then for the serious bacterial infections, UTIs, bacteremias, and meningitis, it was probably around 4.5 or something. So 4 out of, or 5, if you add like HSV, probably a 5% of all those neonates have some infection that is an actionable infection, I call it, an infection that you need to treat either with an antibiotic or an antivirus. Now, if you go down to here, to those who were admitted with fevers, and they did have like a very sizable population there, 960 patients, so those who are febrile, they ended up having, 17% of those had some viral infection. That was documented. 0.3, so not a large number, but also not insignificant number who ended up having HSV, so 3 in 1,000. And if you look at bacterial infection, probably a conglomerate of around 14%. Please let me touch on this for a second. So 14% of all patients, 15% of all patients who have fevers have some kind of invasive infection, bacterial and HSV in this population. Very high. You will never see an incidence that high anywhere else during childhood, and perhaps anywhere else in life ever. So UTIs were by far the most prominent. Bacteremia without a source was 3.1, and then meningitis, 1 in 100. 1.3% had bacterial meningitis. So enough said on those. What were the pathogens that were recovered? And these pathogens should not come to you as a major surprise. We should start with bacteria. By far, number one is group B strep, GBS, okay? A far second were E. coli, and they had a couple of Enterococcus faecalis, I think, sprinkled in there. So no listeria, but GBS and E. coli, number one, and number two, probably with other Enterobacteriaceae and gram-negative rods, being the most two bacterial pathogens that we recover in this particular age group. Viruses were also prominent. RSV, my favorite. So of all viruses, 50% or close to 50% were due to RSV. Rhinoviruses and enteroviruses, we've heard these days about D68 and stuff. This was not D68 times, but as you know, there are other enteroviruses that can cause neonatal infection. Enteroviruses / rhinoviruses account around 30% of all infections, all viral infections, and you can see herpes simplex virus was 2% out of all viruses. What were the disease entities? Certainly coming in with a respiratory tract infection like a runny nose or rhinorrhea, or even like a pneumonia, probably in the setting of a viral process was the most common, followed by a urinary tract infection. This is clearly number one, bacterial process like we talked about, and then there is bacteremia and meningitis also. So they did find 10 neonates with HSV infection. You tell me, thousands, but they only found 10 neonates out of 5,000-6,000. Do we need to worry about it? The answer is absolutely. This is one. It's an illness that we can treat, and hopefully we can treat effectively if we can get it early. And two, this is a disease with very high morbidity and mortality, and time is of the essence. So the number one thing not to forget in your fever workup in a neonate is to think about HSV. HSV can present in 3 different diseases. We're not going to make this lectures about HSV per se, but please remember that it can cause many different neonatal disease phenotype. SEM is skin, eye, and mucous membrane. CNS is basically just meningitis, and disseminated infection is basically when the patient is viremic. And the definition of viremia is basically the liver being attacked, and as you can see in disseminated infection, you see AST being elevated. So liver enzymes being elevated. So for those kids, you sometimes see a rash, so a very careful and close physical examination is very important, paramount. Look at the creases, in the diaper area. Look at, the neonatal probe that they put during delivery. That site where you breach the integument is going to be important. Any instrumentation, any site of instrumentation, any breach of the skin is probably going to be the place where HSV can actually sort of invade and set up shop. So important to look in those areas for rashes. So vesicular rashes is going to be important when we think about, SEM disease. For CNS disease, clearly, you will see CSF that has some pleocytosis in it, 250, 800, not like or 1,000, not really like, a very large amount of pleocytosis that we see, but pleocytosis significant enough to be abnormal. And then for disseminated disease, please direct your attention to your liver function tests here. Some people actually even did not present with fever, they present hypothermic, 33.7. And unfortunately, some of these kids end up not making it. So those with disseminated disease is 7 out of 10, a mortality of 30%. And in disseminated disease, at least in this theory, few patients granted, but a mortality of 100%. So moving on from the neonate to a little bit older, in the first 1 to 2 months of age, and then 2 to 3 months of age, as you can see, serious bacterial infection. This was a meta-analysis from many years ago, but probably the prevalence of these infections probably are similar. So 8.7 in the first month of life, 5.9 in the second month of life, and in the third month of life, 2 to 3, 8.8. So also significantly problematic in there, as did the meningitis and the bacteremia. So 3.7 initially, 1.6, and then 3.1. So this is, the highest, time of risk for these newborn patients. So moving on to the suggested workup. So again, stemming from what I just presented, I like my septic workup in the first 4 weeks of life to include your blood, your urine, and your lumbar puncture. I also like liver function tests to be obtained as well. I'm a big fan of CRP. So 10 to 15% will stay in the hospital because of some invasive bacterial or viral infection. So we might as well document what their presenting inflammatory marker is and how that inflammatory marker trends to treat their infection, and hopefully they get better. So CBC with differential, Chem7, that would include your electrolytes and BUN and creatinine, liver function test, CRP, C-reactive protein, blood culture. Please make sure you clean well. Urine analysis and urine cultures, unacceptable to get your urine culture in a neonate or in an infant by bag. Or midstream for that matter. All cultures should be through the catheterized route. If there are respiratory symptoms, please obtain a viral panel and a chest x-ray if you feel that would be helpful. An LP is mandatory in the first 4 weeks of life, like we talked about. In the first 3 months of life, any sign of toxicity, any biochemical analysis that suggests an invasive infection, any clinical examination that worries you about an invasive process, you should probably do an LP. A kid that is irritable even when there is no fever, a fontanelle that is bulging, a neck that is moving, etc., etc. But please, when you do the lumbar puncture, and if you can spare a few drops for enterovirus and for HSV. Those now we have, PCRs. I'm not sure if they are run at your institution or through your office, but certainly these things are available. At Mass General, we have those, in a day or two. So they are meaningful, both in the, the thick of the treatment, but also in terms of cohorting and trying to just, assign a diagnosis to a specific patient. Antimicrobial therapy in this age group, AMP and GENT is the staple, as you might know. AMP and cefotaxime is also an acceptable alternative. Ceftriaxone we don't use in the neonate because it causes some biliary sludging and stuff like that, and in somebody who's already struggling with bilirubin, probably ceftriaxone is not the best way to do. And then plus or minus acyclovir. Again, if there are any skin issues, toxicity, AST, ALT that are increased, or perhaps some pleocytosis on the CSF, any one of those, at least in my book, will need an empiric initiation of acyclovir. So please think about acyclovir again for HSV. In children who are older than neonates, 1 to 3 months of age, ceftriaxone is acceptable. We talk about listeriosis. I've never seen it. So, putting ampicillin, adding ampicillin to ceftriaxone is a reasonable thing. If the child is sick, vancomycin. If there is cellulitis, vancomycin. If you're worried about an osteogenic process or a meningitic process, make sure you use vancomycin. And again, high doses of vancomycin are suggested. This is a talk for another time, but vancomycin, we're struggling a little bit with the suggested startup doses and getting them to the levels, the therapeutic troughs that we would like them to be. Acyclovir, we talked about that specifically in the neonate. Now you can actually see it postnatally. So postnatal acquired HSV is usually acquired through an infected mom or grandma or a sibling with maybe like herpes, blisters and stuff like that, kissing the baby, etc., etc. So it's not totally out of the picture when you move on from the neonatal period to the young child. All febrile neonates should be hospitalized. I'm sure you know that. Well-appearing older siblings or children, rather, 1 to 3 months of age, you can send them home if they are, reassuring examination. If you are like, if you got the blood and the urine as appropriate, and many of those we actually give a dose of ceftriaxone and we send them on their way with specific instructions to the family and a very close follow-up with a pediatrician the day after, either to continue another dose of ceftriaxone, or to stop it if the fever has resolved and they continue to look well. So in this particular child, going back to case number 1, this is a febrile child, again, the highest, most problematic period of life with significant invasive infections. You can see basically abnormal AST and ALT, so abnormal liver function test, and a CSF that suggests pleocytosis. In this particular age group, with this particular set of data, this is a child that I would start both on ampicillin and gentamicin, covering for bacteria, but also starting on acyclovir. I wanted to throw in a slide in there. Dave Kimberlin and Dick Whitley from UAB have been looking at neonatal viruses for a long, long time, and they were the pioneers in the high-dose acyclovir that now we know is, the staple of, acyclovir dosing in the neonate. And actually, in the olden days, 60 per kilo is the way. 30 per kilo is the way to go. 10 per kilo divided 3 times a day, and now that dose is doubled. Because of their work, they had shown that with what they called at the time high-dose acyclovir, 60 per kilo, you decrease mortality, but you also decrease the severe morbidity that are associated with this particular disease process. So 60 per kilo is what we use, and actually most recently, the guidelines are to use 20 per kilo 3 times a day, all the way up to age 12. So please, if you want to use acyclovir, use that correct doses. So moving on to case number 2, and then after that we will talk about fevers in the older population here. So this is an 18-month-old now, a little bit older, who started daycare 6 months ago. His mother brings him to your office, so you've been caring for this child since he was born. So his mother brings him to the office because he's had 5 colds with fevers since daycare has started. So over the course of 6 months, he's had 5 cold episodes. This patient has otherwise been totally healthy. He has 2 older siblings in elementary school, and you have advised his parents numerous times to quit smoking. Again, true story. Which statement below is correct? A, parental smoking is unrelated to the incidence of viral illnesses in this age group. B, 5 respiratory infections in 6 months seems quite a lot. A referral to immunology, you suspect an immune deficiency and you want to refer this child to an immunologist, that's B. C, there's no reason for alarm at this point, as this pattern of illness is quite common for this age with these many risk factors. And then D, you might want to get some blood work. CBC and immunoglobulin quantification profile would be your next step, and you wouldn't refer if these results are normal. So let's walk through the next few slides together, and then after that we're going to try to answer case number 2. So in the in the child who is older than 3 months of age, so between 3 months and 3 years, so 3 to 36 months of age, the fevers are again problematic, as in most cases they signify underlying infections. So, and this is a study that is, 14, 15 years old now. Just wanted to put that up to tell you about the epidemiology pre our pneumococcal vaccinations. So as you can see, they call it bacteria. 56% had bacteria of all those who presented to primary care offices. Again, they had thousands of patients that they followed. Not very, homogeneous population, I have to say, and their tools are, again, not homogeneous. But the bottom line, you can see the point. 56 or 60% had some form of a bacterial illness, and they put acute otitis media in that process. Those were the days where everybody with otitis would get treated with antibiotics. Days have changed since then. So 48% of all visits were acute otitis media. 35% had a non-specific viral infection. And again, that was the time when a lot of our diagnostics, just bedside diagnostics or point-of-care diagnostics were not present, like rapid RSV or rapid flu. So 35%. 4% really had a specific viral infection, like, maybe croup or roseola or perhaps varicella. A recognizable viral pattern. And just a small minority, 5%, had an FUO. The difference really was not earth-shattering when you compare those who present with low-grade or moderate-grade fevers to those with high-grade fevers. But really what I wanted to tell you here is that the phenotype of illness has not changed much in the last 15 years. So in this particular age group, otitis media is something that we see most often. And non-specific URI, viral URI now, with our improved point-of-care testing, our rapid RSV, our rapid influenza, these non-specific URIs become much more specific, and we give a name and a pathogen to those phenotype of illnesses. And actually, there's ongoing effort now not only to do rapid testing for some of these, influenza and RSV, and I know for a fact that there are other viruses and perhaps other pathogens, including atypical bacterial pathogens. There's like significant work trying to be made in order to just expedite therapeutics at bedside, geared toward like a much larger group of pathogen. Non-specific or specific viral illnesses, again, croup and bronchiolitis is another one that you should see specifically this time of year, and you will continue to see. SSTIs, skin and soft tissue infections, osteoarticular infections, probably to a much lesser degree of incidence. Now, occult infections are the nightmare of a pediatrician, right? A 3 or a 4 or 5 year old is not going to tell you about their urinary symptoms. Maybe mom will come and say, oh, when I change diaper, the smell is bad, or I can see a little bit of blood in the diaper, and that will clue you in a little bit. But, this is the most affected site of bacterial infection, and probably this is one of the hardest one to diagnose. Risk factors, RF stands for risk factors, are girls and uncircumcised male, as you must already know. Now, pneumonia is another challenging clinical diagnosis, and exactly try to, with your small stethoscope, try to just, localize for, clinical findings in a crying, 2-year-old or something. Very, very tough to do. And there's actually a study now, a fairly old one, that documented even with good clinical examination, in a child who has high fevers, more than 39 degrees, and a white cell count more than 20,000, the incidence of pneumonia, bacterial pneumonia, a focal consolidated process, is around 20 to 30%, even when your stethoscope is telling you otherwise. So think about those kids with high fevers and you obtained a CBC and the white cell count was 25,000. So I think, it becomes like a little bit sort of really mandatory, but very, highly suggestive to get a chest x-ray in that particular patient. Bacteremia, we now are fortunate enough to have the pneumococcal vaccine, PCV7 initially, and more recently PCV13, and that certainly has affected the incidence of invasive pneumococcal diseases. We'll talk about this in the coming slide. The 5% incidence pre-vaccine is now down to around 1%. Think about doing blood cultures. Think about starting empiric antibiotics in the olden days, again, pre-vaccines. I used to practice in Lebanon before coming to the US. So all these kids would come in. We would just, obtain blood and urine, give a shot of ceftriaxone, and then ask them to see their pediatrician the next, the next day or so. This used to make sense, even in the US used to make sense, but now with the dwindling incidence of invasive pneumococcal disease, probably does not make sense anymore. Clearly, if somebody is toxic or ill-appearing, please do that. You might want to admit as well. Meningitis, hopefully as they grow older, you can start seeing some symptoms, a bulging fontanelle, a neck that does not move, or extreme irritability. And when I say irritability, I mean irritability not only during the fever episode, but also when they are afebrile. So between those fever episodes, their temperature is 37 and they can't stop crying, or lethargic, or otherwise. So, as promised, this is the epidemiology of invasive pneumococcal diseases. We have enough data to make some conclusions about the PCV7 effect, and as you can see, sort of pre-PCV7, IPD is invasive pneumococcal disorders or diseases. It used to be like in the order of more than 10, 12 in 100,000 children. And as we started, the application of PCV7, you can see the incidence of IPD significantly decreasing. Actually, by 2003, that rate has halved from 12 to around 6. And you see that trend, both correct for pneumonia. That black square is pneumonia. The triangle is for bacteremia, and you can see the incidence declining 1 year after another. Meningitis, there's also some decline, although the rates, are not as high, again, as you predict them to be. What is worrisome, and this is unfortunate, is that, yes, we were seeing less pneumonias, but unfortunately the pneumonias that we see them being a little bit more complicated. And the reasons behind this are very numerous, so we're not going to go into this. But suffice for the elements of this lecture to know that pneumonia in this day and age is compounded by the vaccine effect, but also by the fact that those who do come in vaccinated, they sometimes have serotypes that are problematic, not included in the vaccine, and those serotypes might affect a more problematic disease phenotype, a pneumonia with effusions or empyema, a more problematic part. So you can see the hospitalization rate with invasive bacterial and invasive pneumococcal disease has increased, and that is throughout all age groups. Now, in this particular age group, again, in the young child, your diagnostic approach should be guided by your clinical appearance. It's easy when it is, right? It's easy when you see, an otitis media or a very snotty child with clearly, viral. It's easy when you see a cellulitis. It's easy when you have, a toxic child who would not wake up during your examination. Easy but unfortunate. But the bottom line is, it is easy when your clinical, when your clinical exam gives you part or a large part of the answer. In fully immunized children who are well appearing, I don't tend to worry too much, Sometimes no testing at all, or perhaps minimal testing, specifically thinking again about the urine, that occult process that is very hard to diagnose. You might want to get a urine culture before you send them home. In ill-appearing blood urine and perhaps CSF, if you suspect meningitis, is the way to go. And again, as stated previously, your stethoscope tells you there's no pneumonia, but the child is febrile. The white cell count is very elevated. You have 20 to 30% chance of missing a pneumonia in there. So perhaps you would want to think about doing an X-ray. Now, moving on from fevers per se, and this is something that I encountered in my clinic as well, and I thought this probably we can employ, the rest of the time we have to just talk about recurrent fevers. In clinic these days I see, MRSA colonization, decontamination, I see Lyme disease, but I also see a lot of those kids referred by their pediatrician because they keep having fevers, they keep having recurrent infections. So what's up with that? I'm going to walk you through what I try to do in my clinic, and perhaps before that, we can talk about a good clinical examination. I always want to know what they've been doing, where they had been, travel history, exposures, including ill contacts and vaccinations. And then after your clinical examination is complete, I think if you ought to find an answer, that answer is already there, and maybe doing additional diagnostics are only going to be helpful in a very small minority of patients. So what I find useful is, again, a good history taking, think about travels, think about exposures, think about sick contacts, think about immunization, and do a very thorough clinical examination, time permitting. The next most useful diagnostic tool that I find helpful to my own self is a fever calendar. Numerous times, the parent is trying to remember, okay, in March last year we had one fever, perhaps it was with a rash, perhaps it wasn't with a rash, and then 2 weeks later or not, maybe 2 months later. So anyways, you get the point. A fever calendar, and this is a template of a fever calendar that I use, it will give very important data for your next visit. For those kids who come to see me in clinic, I very rarely send them to the laboratory or for a chest x-ray or an abdominal scan or maybe like a cardiac ultrasound the very first day or the very first time we meet. If I was suspicious for endocarditis, I sure would. But most often than not, this is what I send them home with. I send them home with a fever calendar. So do not rely on your memory. Rely on that piece of paper that you're going to be filling every day or every time you have a fever. So date and time of the fever is the first column. Fever measurement, how high that fever is, how did you obtain it. So again, in the less than 2 or 3 years of age, I suggest this being done rectally. TA is an acceptable, or oral or axillary are all acceptable alternatives later on in life. What are the associated symptoms? Write down here what other things are going on: vomiting, diarrhea, rashes, abdominal pain, joint issues, eye disease, etc., mouth sores. So this is where the associated symptoms go. And then, jot down notes. We went to see the PCP, we waited for 30 minutes and never end up being seen. Or, we showed up to the emergency room and this is what ended up happening. So, and then when I see them in follow-up a month or 2 later, I go back to that template, to that fever calendar, and I walk through things with them. Most kids with recurrent fevers, recurrent infections, end up having very little or nothing at all. So here I call them normal child. It's a normal child, it's the child with repetitive exposures. So it is a child whose immune system is learning. That's what it is. Okay? Now we don't remember our early childhood or childhood any longer, but basically, what ends up happening is that with our novel immune system as we are born and we age through life, each particular experience with a novel virus is usually a symptomatic experience. So we get, we get influenza the first time, we're symptomatic. We get rhinovirus the first time, we're symptomatic. We get enterovirus the first time, we're symptomatic. We get, RSV the first time, we're symptomatic, and with RSV the second time, and the third time, etc. So what I'm actually trying to say is that as our immune system goes through the experience of processing the new pathogens, we are always experiencing some degree of symptoms. And this is life. This is the nature of the first 1, 2, 3, 4 years of life. Your child will be sick forever. And this is normal. So the normal child with repetitive exposure makes up probably a little bit more than 50, perhaps 60% of all children with particular problems with recurrent fevers. We'll walk through this in a second. Children with atopic disease is something that I always see in clinic. Children with asthma and respiratory infections all the time. Children with atopic sinusitis, allergic sinusitis. So these kids, their mucous membranes are constantly under assault, and our nose is really not, the healthiest place. So they get recurrent sinus infections. They get recurrent rhinosinusitis with viruses and otherwise. And then I'm sure in your practice you do have your fair share of children with chronic diseases, those kids with IBD or with cerebral palsy or recurrent seizures, etc., etc. And then the child with immunodeficiency makes only perhaps maybe up to 5% of all children with recurrent infections. And we will talk about this in just a second, hopefully. So this remains one of the best study looking at incidence of respiratory infections. Febrile respiratory infection the first few years of life. And this is, another observational study from the first year to the 12th year of life. And then as you can see, during the first few years, your incidence of respiratory symptom is 3 or 4 events a year. And then this is your standard deviation, your 2 standard deviation, which is up to 7 or perhaps 8. So it's not uncommon during the first 1 or 2 years of life to have 5, 6, 7, 8, perhaps, respiratory illnesses, and hence, febrile diseases as well. And this incidence, as predicted, as your immune system moves on with relying only on its adaptive immunity to actually, from the innate immunity to adaptive learned immunity, then the incidence starts coming down. And, by the time you're 6 or 10, you probably get 1 or 2 infections a year here. Before I move on to the next slide, I just want to show you here, or maybe talk to you about sinusitis per se. So sinusitis should always be a red flag. There's something wrong if you diagnose sinusitis. If you're clinically, diagnose sinusitis in the first 1 or 2 years of life. Sinusitis is not a common, not the allergic sinusitis, but the bacterial sinusitis. You should start thinking about, is there like underlying allergy, or more importantly, is there some immune process, an immunodeficiency that predisposes these kids? Kids with humoral immunodeficiency can have recurrent sinusitis, as you know. CF kids with CF also can have recurrent sinusitis. So sinusitis is a red flag as far as I am concerned. Now, what is the normal duration of illness? So again, thousands of children, thousands of episodes that they followed, and as you can see, weeks, 1 to 2 weeks, actually 2 weeks here with a standard deviation of 1.3 is the average duration per common cold episode. So good news for the parent, your child is going to be sick 5, 6, 7, 8 times during the first 1 or 2 years of life, and each episode is going to last for 2 weeks, perhaps 3. So during, so that feeling of my son being sick all the time is not an incorrect feeling. It's just you're sick, or your child is sick all the time. Now, these are one of my favorite slides. This is like half a decade ago, from 1953, but I think it's still true now. It's just these folks, Badger et al., tried to figure out what is normal for these kids with recurrent exposures. And at the time, I know you can't see this. This is from old photocopied journals. So 8 to 10 times a year. And then females are less problematic than males. Males tend to share their respiratory secretions a little bit more intimately until they get a little bit mature and stop doing that. Now, moving on, so that's the gender effect, school attendance. So, you learn more and you learn faster and you are sicker if you have more exposure. So at the time it was school. These days it's daycare, so kids at school experience even more. Kids in daycare experience even more symptoms. And this is a busy slide, but I think it's an important slide. It's always nice to tell the family, oh, your child has a virus, please go home. This fever is coming from a virus. It would be nice to know what kind of virus to expect during year time. And this is probably true for most of the U.S., I have to say. Certainly up here in the Northeast it is. So in this time of year, and perhaps a month or two ago, rhinoviruses preponderate. So you see a peak in August to September where your rhinoviruses are like all the way up. And as the rhinovirus comes down, as the season comes down, you start seeing uptake of the parainfluenza virus. So PIV is actually sometime in October, November, December, the peak starts to come down. And as the peak starts to come down of PIV, you start seeing RSV on the upswing, RSV, the peak is usually in January, February, plus or minus 2 months is basically what we see the RSV season being. It changes from year to year, but the bottom line, as PIV comes down, RSV peaks up, and then influenza, and this is the season influenza. The influenza season probably follows the RSV season, and again, as the influenza comes down, you start seeing the rhinoviruses coming up. You might have here the green part, which is maybe life is a little bit better for kids out there in school and us in healthcare, but we still see respiratory viruses here. The one major virus that is missing here, so we have respiratory panel, we have like a DFA-based assay that tests for parainfluenza, respiratory, syncytial virus, influenza, and also we have a test for adenovirus. Adenovirus is not present because it's not seasonal. Adenovirus can be seen any time of year. So think about that and as we move forward. Now, Exposure to cigarette smoking, old data, but still significant, suggesting that both in infant, children, and perhaps adult, exposure to cigarette smoke is not good, and it will increase, it increases the incidence of lower respiratory tract illnesses. It increases the incidence of, nasopharyngitis, sinusitis. So smoking is clearly, it clearly increases the risk of respiratory infections. So to finish up, recognizing the normal child. So once these kids are sick, they have fevers, they have runny nose, they have cough, they might, feel terrible. But then as you plot them over a few month period, perhaps 6 months or a year, these children have normal development. If you give them antibiotics for otitis, they respond very quickly as expected. And then between the episodes of fevers, they are totally healthy. Okay, so this is the normal child. This is the child with repetitive exposure, and this child represents 55% again of those children with recurrent infections. So the correct answer to case number 2, this is a totally normal child, right? He's 18-month-old, just started daycare or preschool. He's had 5 cold episodes, nothing exciting. Kids in elementary school, so more goodies to bring back home, and then parents both are smokers. So again, higher incidence of respiratory tract infection. So at this particular point in time, there's no reason for alarm. No blood testing is needed, no referral to anybody is needed, close observation, and perhaps trying to convince the family to quit smoking again. One quick slide about the child with atopic disease. Again, these are children with around 30% that make up 30% of those kids with recurrent fevers and infection. And as I told you, there might be problems with the respiratory epithelium. It's always inflamed and it's always prone to being infected. So these kids do come with recurrent upper respiratory tract infection, perhaps sinusitis, otitis media as well, rhinitis, and perhaps lower respiratory tract infection. The child with a chronic illness, 10%, as I alluded to earlier on. So these are the kids, who have some known syndromes like, trisomy 21 or trisomy 18 or so. Kids who harbor resistant organisms because they've been in the hospital many times and then have recurrent abscesses. Kids who have cystic fibrosis or perhaps immunosuppressed because of the treatment for their IBD, etc. Kids who recurrently aspirate because they have cerebral palsy, kids who have foreign bodies because, the gut cannot, it doesn't work and you have to feed them enterally, etc., or parenterally rather. So all these things can be problematic, and all those are, opportunities for infections to occur. And this is probably a child that can come with recurrent infections. And, the scope of these recurrent infections, the scope of recurrent fevers is, very individualized, very personal, either to that particular patient or to that particular disease or disease illness. Now, the child with immunodeficiency, I'm not sure how many of you do see that, but immunodeficiencies in general can be primary or secondary, okay? So primary immunodeficiency is, you're born with it, and secondary immunodeficiency, it's acquired. It's not acquired because, you acquired HIV through, different mechanisms, or because, you have cancer and we're giving you, antineoplastic medications or oncological products, or you have IBD and you are on steroids all the time, or you have sarcoid or SLE or rheumatoid arthritis and we are suppressing you with methotrexate, etc., etc. So for these particular kids, their immune system is not working well, and it would be nice for you to be familiar with that particular patient and try to familiarize yourself with what kind of illnesses each and every patient can get in that specific disease, in that specific disease entity or patient population. Folks on methotrexate are going to have a specific different set of illnesses than folks with, a G-tube, or folks with a line because they're receiving, product X or Y. And primary immune deficiency, so these are, those secondary acquired problems are hopefully, they are already diagnosed. You're not going to have problems diagnosing them. So maybe I can talk a little bit more about the primary immunodeficiencies here for the next 2 or 3 minutes. So the child with immunodeficiency, maybe we can start with this right here. And I don't want to make this like an immunological talk or anything, but this is an antigen-presenting cell. It's a very quick slide to just describe this schematic illustration how the immune response, so how the immune system works after antigenic stimulation. You can see an antigen-presenting cell here. An antigen gets chewed up. It basically gets presented over the surface, and the first thing that happens is this T cell basically comes, plugs itself on the APC, and then asks the B cell to come about. And then the B cell will develop into a plasma cell producing antibody. So there is really very rare instances where you only have a T cell problem. And clearly because of this slide, right? If you have a T cell problem, you certainly have a B cell problem consequently. So most primary immunodeficiency are problems with your B cells or combined B and T problems. And this is important because when we think about primary immunodeficiency, oh my God, what test am I going to send? How do these patients present, et cetera, they present differently. T cell problem is usually a secondary immune deficiency problem like HIV or cytotoxic medications from oncology or otherwise, versus the PI, the primary immunodeficiency, which are mainly B cells, okay, not T cells, and those presents with problems with humoral, antibody production. And the set of the disease processes for both B and T are so different, then hopefully if somebody shows up with cryptosporidium in their stool and weight loss, you're not going to be straying into your B, you're going to stray into a little bit into your T. So the next few slides, they are a bit, hopefully they have a lot of information in them, and I'm not going to go into specific information there. This is for your own leisure time. When you have a little bit more time to think about, immunodeficiencies, you can go into individual ones. But let me just spend 1 minute here talking about the warning signs of primary immunodeficiency. And you can download this flyer online through the NIH and the CDC. But basically, when do you start worry about a primary immunodeficiency? I know it's very tough to see, but this is basically here for kids who have more than 4 or 5 infections every year, who basically have sinusitis problems. Ding, ding, ding. Again, sinusitis is a problem. And then basically here they take antibiotics forever. They are hospitalized on multiple occasions. They do not grow well. They have abscesses and deep skin infections. They have thrush. Thrush is another problem that we see. Again, they need to get IV antibiotics rather than oral antibiotics for somewhat simpler infections. And basically, they don't grow well as well. And there's a family history here, number 10, of a primary immunodeficiency. When you think about B-cell deficiencies, these are the disease entities with names, what their common names are, what the laboratory features in order to diagnose those. But let me just spend like 30 seconds here talking about, the associated infections and the associated diseases. And in B-cell deficiencies, so B-cells, humoral deficiencies, antibody production, you see problems with encapsulated bacteria, Streptococcus pneumonia, Haemophilus influenza, etc., etc. For gastrointestinal illnesses, you see parasitic infection, okay, not viral infection. The only virus infection that you might see in B-cell immunodeficiency is enterovirus. So a neonate basically presenting with enteroviral meningitis, try to think about B-cell deficiency and hopefully screen for, common variable immunodeficiency or something. So we'll talk about that in a second. For your T-cell problems, you still will see, remember, T-cell can sometimes also have problems with your B cells, antibody production. That's why you would still see problems with pneumonia and lower respiratory tract infection with encapsulated bacteria, but you will start seeing fungal pathogens. So this is your HIV disease phenotype, right? Thrush that wouldn't go away, cytomegalovirus, CMV colitis, CMV pneumonitis, etc. Non-tuberculous mycobacteria, and then opportunistic infections like cryptosporidium, and then Pneumocystis carinii. The name has changed. So we will zoom past those, and again, these are there for when you have time to look at them. your role as a pediatrician or perhaps as a hospitalist is to think about the recurrent infections. If you have any thoughts about, these recurrent infections being problematic or harbinger of like an underlying process, try to decide if it is like a T-cell disorder or a B-cell disorder. And again, if it is a T-cell disorder, you'll see lots more fungus. You'll see more opportunistic and viral infections, and for the B cells, you'll see a little bit more of a bacterial infection. And all you are asked to do, perhaps, is to do a CBC, an immunoglobulin profile, just send for immunoglobulin profile, and perhaps specific antibody responses. Specific antibody responses should follow your vaccines, vaccine profile. So, pneumococcal titers or Hep B, or tetanus, you can actually send titers to just interrogate the immune system and try to figure out if a specific vaccine has produced the set immunity that it should produce. Now, for viral infections, an HIV and perhaps a CBC and a DEF is all you could do from clinic. There are tons of genetic testing. We know probably about 100 now primary immunodeficiency disorder, and probably as many genetic testing that we have. So you can actually test for these specific testing for these specific disorders as appropriate. So I think I'm going to end up with my case number 3 here. And this was a case that I saw maybe like 6 months ago, I should say. So this is a 3-year-old boy who came to my clinic with recurrent fevers, recurrent infections since the age of 18 months. He's been diagnosed many times with an upper respiratory tract infection. Those have been made frequently. He's received multiple antibiotic courses, and he had not improved on those antibiotic courses. So the first time that I saw him, had no idea what the child has. So I sent him with a fever calendar. So I sent him with a fever calendar, and I asked him to come and see me, soon if symptoms escalate, or in 4 or 5 months, I think. And then by the time he came back after 4 or 5 months, I had a pretty good idea of what's going on then. So his fever episodes, he came in actually the second time to see me during a fever episode, and I wanted to see him during a febrile episode. So this is what happened. So at the time of his second visit, I knew that his fevers usually are abrupt. Monday he's fine. Tuesday his fever is 104. It could go to 104, as you can see, 104, 104.5. Usually the fever episodes last around 3 to 5 days. Initially, during the first maybe 6 or 12 months of his symptoms, these episodes were erratic. But then when he came to me with that fever calendar, I noticed some interval, a fever interval of 3 to 4 weeks at the time. These episodes are usually associated with pharyngitis. And his pediatrician and the nurse practitioner at his office had done a very good job, like swabbing his throat every time he shows up with a sore throat, and not once, he was strep positive. He also complained of painful adenitis, and during 2 out of the 4 episodes that presented to me with his fever calendar, he had like painful adenitis as well. Otherwise healthy between episodes, growing well. And, by the time I saw him, you could see he's not a gigantic guy, but he was following his curve. 14% when he was 2. When he was 3, it was around 15%. His height was 38% at 2, and then 34 when I saw him again. So the kid was fully vaccinated. His past history was totally unrevealing. And again, other those repetitive infections and diagnosis of AOMs and URIs and antibiotics, nothing else I could elicit. So in the office, when he came to see me, he was febrile, and I looked closely into his mouth. Not looking only at his tonsils, but also looking at his cheeks. And I could see there maybe 1, perhaps like 2 painless ulcers on the right inner cheek. So what is this patient's most likely diagnosis? A, Marshall's syndrome. B, cyclic neutropenia. C, FMF, familial Mediterranean fever. D, hyper IgD syndrome. And E, TRAPS, tumor necrosis factor receptor associated periodic fever syndrome. So recurrent fever syndromes, usually these patients present to us, and then after they show up to our clinic, we either take care of it because it's PFAPA, and this is the most common one, and I'll talk about PFAPA in a second, or there are some other disease entity, probably non-infectious recurrent entities, or autoinflammatory, not autoimmune, autoinflammatory entity, and then we move them, we actually direct them towards our rheumatologist. PFAPA is the most common recurrent fever syndrome. Okay? Some of these fever syndromes have some periodicity between episodes, and usually for PFAPA, PFAPA stands for periodic fever, adenitis, pharyngitis, and aphthous ulcers. The other name for it is Marshall syndrome. So Dr. Marshall from, I guess it was Vanderbilt in the 1980s. So PFAPA is a diagnosis that is a clinical diagnosis. There's no test. There's no special laboratory technique or a test to use. Usually you diagnose it with a fever calendar. You usually look at the associated symptoms, and the associated symptoms basically reside in the name. These kids usually outgrow these fever episodes by early adolescence, and really, in treatment-wise, some people believe, including myself, that tonsillectomy is actually a curative procedure, but others have used, including myself, we've used just 1 or 2 doses of prednisone, steroids, to just blunt the fever episode as it starts. And this provides some relief, but also a diagnostic, very strong diagnostic modality per se. These fevers are not harmful. They usually last 3 to 5 days. Again, it's probably the most common recurrent fever syndrome that you would diagnose here in the US. In Europe and otherwise in the Mediterranean, there are other fever syndromes, recurrent fever syndromes that can come your way. I don't think we're going to talk about this today, just because of the lack of time, but also because these are rare for you to see in this country. So the correct diagnosis for patient A is PFAPA, Marshall syndrome. And these, the periodic fever is clearly there, but the aphthous also, the pharyngitis and the adenitis, they do not need to be all present in one single fever episode. So they can come along, one would be here, the other one would be there. And the aphthous ulcer is the hardest one in my experience to diagnose, Folks like us, pediatrician, we want to go into the mouth and look to the back of the mouth to look at the tonsils. And, for that 1.5 seconds that we have looking at the tonsils, we have no time to look elsewhere. If you are concerned about PFAPA because of the periodicity of the fever and perhaps, a disease phenotype that is suggestive of such, you have to take your time. Looking on the gingiva, on the tongue, under the tongue, and also inside the cheeks. And this is how you're diagnosed.